Hello, and welcome to another live broadcast with MedStar Health. Today, we're discussing the differences between IBS and IBD, two very common GI issues. Irritable Bowel Syndrome, or IBS, and Inflammatory Bowel Disease, or IBD, are two conditions that affect many Americans each year. IBS is a chronic condition made up of a group of symptoms, including abdominal pain, while IBD refers to inflammation or chronic swelling of the intestines. There is no cure for IBS or IBD, but with proper diagnosis and treatment, you can live a healthy and normal life. We're joined today by three of our experts from MedStar Montgomery Medical Center, Dr. Samer Charbel, Chair of Gastroenterology at MedStar Montgomery Medical Center, Dr. Raina Olson, and Dr. Sunwar Sohal. Our experts will discuss symptoms and treatment for IBS and IBD, and they'll explain the differences between them. So thank you for joining. Stick around, give us a like, let us know that you're watching, and share your questions in the comments. Thank you to all three of you for joining us today. Before we begin, will you please introduce yourselves to our team and our watchers of our broadcast today? I definitely mixed up some of your names, so I apologize for that. So let's introduce yourselves and then we'll get into our questions for today. Dr. Charbel, why don't you start?
Thank you, Karen, and good evening, everyone. I'm Samer Charbel. I'm a gastroenterologist. I've been practicing gastroenterology for the past 15 years. I joined MedStar Montgomery Medical Center and MedStar Gastroenterology a couple of years ago as site director here at the MedStar Montgomery Medical Center. I treat a wide variety of gastrointestinal diseases, including Irritable Bowel Syndrome and Inflammatory Bowel Disease that we will be talking about this evening.
Thank you very much. Dr. Olson?
Hi, my name is Raina Olson. I am a gastroenterologist and do primarily general gastroenterology. I've been a gastroenterologist for 16 years, and I recently moved here from California to be close to the family, and I joined MedStar 2 years ago. I'm happy to be here, especially to shed light on this important topic.
Thank you. We're happy to have you. And Dr. Sohal?
Thank you. My name is Dr. Kunwar Sohal. I'm been practicing GI for 10 years, so I'm the youngest of the three. I also moved here about a year ago from California to be closer to family. Did graduate school here at University of Maryland, so have some roots in the state. And prior to that was in Chapel Hill. But a very important topic to talk about today in terms of IBS and IBD, and happy to be here.
We're happy to have you as well, all three of you. But yeah, sounds like it's a nice place to be, coming back to your family, and we're so happy to have you at MedStar Health. So let's get into our questions. Dr. Charbel, I'll start with you. Can you talk about the symptoms for IBS?
Sure. So IBS can have a wide variety of symptoms, but the most common symptom in IBS is usually abdominal pain. IBS patients report a chronic history of abdominal pain, usually that can range from a mild abdominal pain to bloating to discomfort, and that may or may not be associated with eating. IBS is also associated with changes of bowel movements. IBS patients would describe some degree of changes in their bowel movement. There are different categories of IBS. You can have predominance of constipation, and this is what we call constipation predominant irritable bowel syndrome. Or you can have predominance of diarrhea associated with abdominal pain. Or there's a third category of patients who go back and forth between diarrhea and constipation. So abdominal pain, changes in bowel movements, and some degree of bloating, discomfort, etc. Mucus in the stools are the most common symptoms of IBS.
All right, thank you. Dr. Olson, what about IBD? What are the symptoms of IBD? And are there any overlap symptoms with IBS?
You know, the abdomen is like a crying baby. I often say that to my patients. It doesn't know how to say very many things. So a lot of the symptoms will overlap. So you have abdominal pain, you have diarrhea, often with mucus or blood, you'll have cramping, you'll have weight loss because you have a lack of appetite and you just don't want to eat. Overall, you feel fatigued. You may have fever. Definitely the symptoms of inflammatory bowel disease are more prominent and more severe than IBS for most patients.
All right, thank you very much. Dr. Sohal, most people have heard of Crohn's disease. So when you think about stomach challenges, Crohn's disease comes to mind, being one of the main forms of IBD. Can you talk about Crohn's disease specifically?
Sure. Yeah. I mean, so Crohn's disease is one of the two diagnoses under the larger umbrella of inflammatory bowel diseases. Crohn's disease is different from ulcerative colitis in that it can affect essentially any part of your GI tract, starting with your mouth, going all the way down to the rectum and anus. It's an autoimmune condition, which means that your immune system is heavily involved in the trigger and in the exacerbations of the symptoms. It tends to be slightly more difficult to treat than the other half of inflammatory bowel disease, which is ulcerative colitis. And there's no cure for it, where with ulcerative colitis, there may be a cure depending on if surgery is ever an option for a patient. Fortunately, treatment has improved over the past several years, and we have a lot more weaponry and medications available to treat it now.
Great, thank you very much. Let's talk about causes of IBS and the causes of IBD. Dr. Charbel, I'm going to go back to you. What are those causes?
Sure. So when it comes to irritable bowel syndrome, there are a variety of factors that can play a role. There's no single cause that can lead to irritable bowel syndrome. There are a lot of theories behind the pathophysiology of IBS. A lot of time, patients have what we call hypersensitivity of the intestines, meaning that when we usually eat, the intestines get distended to a certain degree. People who don't have IBS don't feel this distension. On the other hand, patients who have IBS are more hypersensitive. They have what we call visceral hypersensitivity, meaning that they feel this distension and it causes them to have symptoms. There are other factors, some other theories about infections playing a role in IBS. That's why sometimes we have what we call post-infectious IBS. After a certain severe infection, the patients continue to have symptoms of abdominal pain and discomfort, although the infection is gone. And there are some, of course, psychological factors, stress and anxiety, that play a role in the pathophysiology of IBS. When it comes to inflammatory bowel disease, there's definitely a genetic component that can play a role. A lot of patients with Crohn's or ulcerative colitis describe a family history of inflammatory bowel disease, although you don't necessarily need to have a family history. So those are the most common factors, genetic, environmental factors that can contribute to the pathophysiology or to causing those two conditions.
All right, thank you. Dr. Olson, you talked about the symptoms and the overlap in the symptoms between IBS and IBD. Can you have IBS and IBD at the same time?
100%, 100%. Because irritable bowel syndrome is A, B, C, and D, abdominal pain, bloating and gas, C is the constipation, D is the diarrhea. You can have all of those symptoms, even if you have inflammatory bowel disease. So many times when people have inflammatory bowel disease, it's a little confusing to know, well, what is it? Are you in a flare and that's why you have symptoms? Because people with inflammatory bowel disease can have IBS as well. They can have anxiety and stress contributing to their symptoms and it not be the flare at all. On the opposite side, patients who have IBS, unless they develop inflammatory bowel disease, they don't have the inflammatory bowel disease overlay.
It's very interesting. Thank you so much. So we talked, anxiety's been brought up a couple times. Dr. Sohal, can you talk about how psychological symptoms like anxiety and depression, how did they play a role in IBS or IBD?
Well, that's, I get the easy question. So we could talk for an hour about that. You know, I think that the main thing to take away from this is that the brain and the gut are best friends. There is a network of communication between the two. And folks who have issues with mental health disorders tend to have a lot of overlap with dealing with more external stressors, more lability and emotional mental health, and experiencing GI symptoms concurrently. And so the thought is that the brain-gut axis, the communication that occurs between the two can be, as Dr. Charbel mentioned, there's a lot of visceral hypersensitivity. So thresholds that our guts have in terms of when to trigger a signal and when to send that signal up for pain or bloating or nausea varies from person to person. And it's not a one-to-one correlation. Happy people get IBS as well. But folks who have significant issues with anxiety and stress can have more difficult to treat and more frequent issues with IBS. And one of the main things that we talk about in clinic is that you want to make sure that the mental health issues are being addressed and worked up with psychiatrists, psychologists, your primary care doctor, et cetera, because that tends to be the crux of the matter when there's a significant amount of emotional and mental health burden, along with concurrent GI symptoms.
Thank you very much. That's
Can I chime in on that one as well? That was nicely said. I want to point out something that I think many of us say we have butterflies in our stomach. We're really excited about something and we have butterflies. And it's such a cute little word that we use because it explains exactly how we feel. But really, butterflies in the stomach is just a cute way of saying irritable bowel syndrome. So a lot of patients do harbor their nerves in their guts and they do get symptoms. And although that word has been around forever and ever, we're calling it irritable bowel syndrome. The layman probably calls it butterflies in the stomach. And, controlling the anxiety and controlling the nervousness around whatever is happening will definitely improve symptoms.
Mm-hmm.
Yeah, I mean, we have patients who will, students, people who are in high stress jobs there'll be a temporal correlation between, I'm home from vacation and I'm eating what my mom cooks for me and I feel much better, but when I'm in school, my symptoms are much more problematic. And that's sort of a perfect example of external stressors playing a big role in GI symptoms.
Yeah, makes sense. Thank you so much. So I'm going to take a moment to pause to welcome our viewers again, especially those who just joined us. We are here today with 3 of our gastroenterologists from MedStar Montgomery Medical Center, and we're discussing the differences between IBS and IBD. We've talked so far about symptoms and causes and how psychological conditions can affect IBS and IBD. So next we're going to talk about diagnosis as well as treatment options. But if you haven't already, give us a like, let us know you're watching, share this with your friends, and most importantly, take this opportunity to ask any questions that you have for our experts who are here live. Ask them in the comments and we'll be sure to get those over to our experts. So again, thank you all for the 3 of you for all the questions that you've answered so far. I've already learned a lot, but we have more to discuss. So I'm going to go back to Dr. Charbel and ask you about diagnosis. Can you talk about when are people mostly diagnosed with IBD or IBS? Is it during your younger stages of life, older stages of life? Talk to me about that.
Sure. So when it comes to IBS, usually the people are diagnosed earlier on in life, in early adulthood, or sometimes even as teenagers. They start having symptoms of abdominal pain and changes in their bowel movements. Although it can happen at any time, most commonly it starts earlier at a young age. When it comes to IBD, also it's more commonly diagnosed in their 20s or late teens, although it can start at any time in life. And now there's more and more, there's studies showing that, for example, when it comes to Crohn's disease, it can start later on in life in some patients, their 60s and 70s. But in general, younger adults are affected more commonly, although this is inflammatory bowel disease can start at any age. So if we're in a certain age group, we shouldn't feel that symptoms are very, very unlikely to be related to inflammatory bowel disease. It can happen at any age, just more common in the 20s and early 20s or late teens.
It's pretty uncommon for someone to develop irritable bowel syndrome after the age of 50. And sometimes I'll see patients over the age of 50 coming in with symptoms and they self-diagnose themselves with irritable bowel syndrome. And I want to emphasize that usually that doesn't pop up whenever you are 50 plus. So that's a good reason to go and see your gastroenterologist so they can tweeze out, is this really irritable bowel syndrome and you just weren't diagnosed all these years? Or is there something more to it, such as inflammatory bowel disease?
Absolutely. Absolutely. Any new onset symptom should prompt, further investigation, because like we discussed, irritable bowel syndrome is a chronic disease. It usually doesn't happen overnight, very unlikely. So especially in people who are in their 40s and 50s, having a colonoscopy for screening for colon cancer is another thing that we have to remind people of, and and at the same time, we'll be ruling out inflammatory bowel disease in most cases. So I agree, absolutely, Dr. Wilson.
Very good points. Thank you so much. We did get a question, a couple questions that came in from our viewers. Thank you for submitting those. This is a question related to the anxiety conversations that we were having. So Dr. Olson, I'll send this over to you, but of course, anyone can chime in. This question is from Bobby. Thank you, Bobby, for your question. We talked about anxiety creating symptoms for IBS. Can IBS cause anxiety to form? So if you have IBS, could you then have anxiety that comes out of that?
I would say not only 100%, I would say 1,000,000%. That's a great question, Bobby, because when you have symptoms, especially if you don't know what the diagnosis is and your stomach hurts, you're running to the bathroom, you can't go to the bathroom, you look like you're 9 months pregnant, like all of those things worry you because you start going on Dr. Google and everything takes you straight to cancer. So I 100% think that symptoms that are unclear what the reason is will definitely drive anxiety for sure.
Thank you. Makes sense. I'll send this question over to Dr. Charbel. This is from Sonia. Can IBS or IBD cause back pain?
So it's a very good question. So when it comes to IBD, I'm going to divide them into categories. IBD can be associated with rheumatological conditions that can cause joint pain and sometimes back pain. IBD, and specifically ulcerative colitis, can be associated with a condition called ankylosing spondylitis that can cause chronic back pain. When it comes to IBS, sometimes distension and discomfort in the stomach and the abdomen can cause referred back discomfort and back pain. So those conditions can be associated with some degree of back pain, usually lower back pain. But of course, other causes of lower back pain need to be ruled out.
All right. Thank you so much. And thank you, Sonia, for that question. If you have others, feel free to post them in the comments. We'll get to those. I want to go back now to, so we talked about diagnoses. Let's talk a little bit more about IBD and what a flare-up looks like. You hear the term flare-up. Dr. Sohal, I'll turn this one over to you. Can you talk about what is considered an IBD flare-up and what does that look like?
Sure, that's a great question. So depending on, so with Crohn's disease, there's different phenotypes of Crohn's disease. There can be perianal disease. There can be what we call fistulizing disease. There can be stenotic disease. So Crohn's is, I guess I mentioned before, can be more aggressive, and because of the phenotype and the degree of severity, your presentation can vary as well. So if you have stenosing disease, which means that there is a blockage or a narrowing developing, you actually may develop issues of constipation and have more upper GI symptoms where you're having a lot of pain, nausea, and vomiting. If you have perianal fistulizing disease, you may be having issues of fever and tenderness and pain and drainage. If there's more run-of-the-mill and what we see more often from an average patient, you're going to see abdominal pain, changes in bowel habits, usually diarrhea, and bloody or non-bloody in nature. Ulcerative colitis is not a condition that typically leads to things like fistulas. Very rarely can you have things like stenoses or narrowings or blockages develop in the colon. But typically with ulcerative colitis, we see some pain, but mostly diarrhea and bloody diarrhea. So, you know, with Crohn's, it depends on the phenotype. And with ulcerative colitis, it's usually pain, diarrhea, and bleeding.
Okay, thank you so much. I want to go back now to diagnoses. We talked about, Dr. Charbel, you mentioned the age where people are typically diagnosed with IBS and IBD. Can you talk about how do you diagnose between IBD and IBS? Can you talk about the diagnosis process for each of those?
Sure. So the first thing we do is we take a very detailed history. We focus on the patient's symptoms because, you know, usually IBS patients have chronic abdominal discomfort with changes of bowel movements without what we call red flags, meaning that there are certain symptoms that you see in IBD, Crohn's, and ulcerative colitis that you don't see in IBS. For example, blood in the stools, IBS patients with irritable bowel syndrome, do not have blood in the stools, do not have bloody diarrhea. Another thing that we pay attention to is the patient having symptoms at night. Patients with IBS usually don't wake up at night complaining of abdominal pain or diarrhea or urges to go to the bathroom at night while they're sleeping. On the other hand, patients with IBD can have nocturnal symptoms. So we start by collecting the detailed history, seeing if there's blood in the stools, nocturnal symptoms, weight loss, etc. Then most of the time, well, especially when it comes to inflammatory bowel disease, the patient will need endoscopic evaluations based on the description of their symptoms. If they're having upper or lower symptoms, usually most of the time they need a colonoscopy. And at the time of the colonoscopy, we examine the entire colon and we go in the small bowel where Crohn's disease, for example, happens most frequently in the distant and what we call the ileum, which is the last part of the small bowel. So we go there, we see endoscopically if there's any inflammation, and we take biopsies. And this is how we make the diagnosis of inflammatory bowel disease, including Crohn's and ulcerative colitis.
Okay, thank you very much. We've talked about ulcerative colitis a couple of times. Dr. Charbel, you mentioned it. Dr. Sohal, you mentioned it too. Can you, Dr. Sohal, can you talk about what ulcerative colitis is compared to IBS and IBD?
Sure, yeah. So ulcerative colitis is kind of the sibling to Crohn's disease under the inflammatory bowel disease umbrella. And so ulcerative colitis is different in that it is a condition of the colon only, compared to Crohn's, where you can involve any part of the GI tract, including, you know, 20 plus feet of the small intestine, your stomach, etc. Ulcerative colitis, in terms of its depth of involvement, in terms of how much inflammation and how deep that inflammation can be, is typically a little bit more superficial in nature compared to Crohn's disease, but it can also be very difficult to treat. Ulcerative colitis is a condition that is typically continuous in nature when you make the diagnosis, meaning it starts at the rectum, it'll go up to a certain extent and then abruptly stop. But you would say, you might think that, hey, if there's only a small amount involved, like the rectum, it'll be easier to treat. And that's actually not true. Sometimes rectal only disease can be very, very difficult to treat. So it's another autoimmune condition under the inflammatory bowel disease umbrella. There is a cure for it in that, you know, if patient's disease ever gets really severe or non-responsive to therapy, patients do undergo what's called a colectomy, where their colon is removed. And they're technically cured from the condition ulcerative colitis, where with Crohn's, there's no cure.
Right. Wow. Well, that's good that we have a cure for that. At least I know there's no cure yet, like you said, for IBS and IBD. So let's talk about treatment options for IBS and IBD. Dr. Olson, can you talk about after a patient is diagnosed, what are their treatment options, and are they different depending on if you have IBS or IBD?
I want to make sure that the audience understands that IBS and IBD are two completely different diagnoses and entities. I mean, it's not even comparing an apple and an orange, it's comparing an apple and a chair. That's how different they are. Yep. When patients have irritable bowel syndrome, they will never have damage to the lining of their colon. They will never have an increased risk of colon cancer. they will have symptoms. They will be annoyed with the symptoms that they have. They can choose not to do treatment, and that's fine. They can choose to have the discomfort instead, but there will be no harm in making that choice. As opposed to inflammatory bowel disease, there is active inflammation attacking the bowel, and it's essential that that inflammation gets calmed and quieted, because that chronic inflammation will lead to the complications that my partners have talked about. It can lead to increasing colon cancer. So when we talk about treatment in both of them, the treatment in inflammatory bowel disease is essential.
Thanks for making that point. Makes sense.
Yeah,
one
for
thing-
sure.
one
There's
thing-
different, go ahead.
No, go ahead, Rena.
I was going to talk about the different options are, we have plenty of medications that are available to both irritable bowel syndrome and inflammatory bowel disease. I can't combine the two because they're two completely different entities. But to generalize, for irritable bowel syndrome, because we don't really know the cause, all we do is treat the symptoms. So if the abdominal pain is the worst part, we may start a patient on a low dose antidepressant, not for depression, because that's not what it's for, but rather to quiet the visceral hypersensitivity and how sensitive your gut is to gas and bloating. If constipation is your biggest complaint, we give laxatives. If diarrhea is the biggest complaint, we give medications that counteract that. We give natural things such as peppermint or antispasmodics to help quiet the inflammation. We encourage Gas-X or simethicone to help with gas if that seems to be a problem. So all of the medications that we give for IBS are symptom control. Whereas in inflammatory bowel disease, we can give oral medications, we can give intravenous medications or injectable medications to quiet the immune system. Because your immune system, my gosh, we always talk about it being an autoimmune thing. And the way I often describe it to patients is your body is so awesome that it sees something on that bowel that doesn't belong and it goes right after it. So instead of thinking about it like a deficient immune system, I don't. I think about it like an overprotective immune system. Your body is trying to protect you from some bad juju that's sitting on your gut, a bacteria, a virus, enzyme, something that doesn't belong. So the medications are there to quiet the immune system to say, hey, quiet down. You don't need to be so aggressive and attack the bowel. And, of course, we also try to give medications to help diarrhea, but mostly it's aimed at the inflammation and to help the immune system. We try to avoid prednisone, which is a steroid, because of so many side effects that it has. But it's a double-edged sword. We love it because it works so well, but we hate it because it can never be used for long-term treatment because of all the potential side effects.
Yep. Thank you so much. Dr. Sohal, did you have something to add?
Well, I was just going to mention that, so IBS it's a functional condition, right? So functional GI disorders is the big umbrella when it comes to a lot of what we see in our clinics, and IBS is sort of a smaller portion of that. But we can't take a picture or a blood test or an X-ray to show you, the one problem with IBS. And so that's why treatment for it is so multifactorial. You attack it from many different angles and ways. And it's a diagnosis of exclusion, right? It's not something that we can just take, do a colonoscopy and I can tell you have IBS. There's things that we have to work up and exclude before we can say this patient very likely has IBS.
All right. Yep. Thanks for that additional comment. That's great. Dr. Charbel, we talked about this a little bit, or Dr. Olson mentioned some potential complications, especially with IBD if it's not treated. But can you talk about that a little bit further? Someone's out there, they think they have IBD or IBS, but IBD, hearing from Dr. Olson, is really, you have to treat it. What would happen if someone chooses not to treat their IBD?
Absolutely. I think Dr. Olson explained very well the difference between those two big conditions or entities. And yeah, for IBD in specific, it's very important to diagnose those conditions, Crohn's and ulcerative colitis, and treat them early on, because if untreated, there are a lot of complications that that can be a result of untreated inflammatory bowel disease. Those complications can range from significant, for example, bloody stools that can lead to anemia. You can have multiple vitamin deficiencies like vitamin B12, vitamin D. You can have surgical emergencies. The patient can present, for example, with a small bowel obstruction, with severe nausea and vomiting, or they can have abscesses or intra-abdominal infections that can require surgical interventions or placement of drains in the abdominal cavity to drain certain infections. So those are the main things that we want to prevent. And or another complication, for example, in Crohn's disease, is that you can have what we call strictures, which are narrowing in different parts of the gastrointestinal tract that can get to a point where it's very difficult to those fibrotic strictures to respond to medical treatment, and the patient will end up requiring surgery. So we have plenty of studies now, plenty of data showing that it's very important to make the diagnosis early on, because we have medical treatment, including biologic treatment, that can change the natural history of the disease and control the inflammation and prevent the patient from requiring significant surgeries.
All right. Thank you so much. Let's talk about, so we talked about treatment options, especially with IBS. It's really controlling symptoms. For IBD, it's controlling the autoimmune response that's happening in your body. Can we talk about lifestyle changes? Dr. Olson, I'll start with you. Are there specific foods or diets that someone with IBS or IBD should avoid, or activities that they should avoid? We talked a lot about anxiety. So I'm sure there's a lot to talk about here, but what do you recommend to your patients in terms of their lifestyle to help them with these conditions?
It's always hard to give a diet suggestion for either one of these diagnoses because there's not one diet that seems to help patients with IBS or IBD. So really, it's important for them to keep a food journal or pay attention to the foods that seem to bother them. Some patients have lactose intolerance, and when they take dairy products, they have more discomfort. So that's one of the big ones that we see. Restricting your diet is something that I don't like to recommend because it feels hard to do. So instead of telling patients to restrict their diet, I tell them find the foods that work well for you and try to eat more of those and try to eat a variety of those. If you know you can take foods in the squash family, try it cooked, try it raw. That way you're eating the foods that you know are safe foods for you. That way you don't feel like you're restricting foods that maybe sound appealing to you. Alcohol is a big one. If you limit your alcohol, that often will help your gut. If you stay hydrated and drink plenty of water, that always helps, especially if you're having diarrhea, to help counteract the fluid loss. Yeah, that's what I would say. Okay. It's just, I always joke that when you go into Barnes and Noble and there's 300 books on a diet for irritable bowel syndrome, that means that probably none of them are correct. But in general, over the years, I have found that the Mediterranean diet seems to work best because it's the least restrictive, and patients do well with it. Do you guys have more to add? What do you say to your patients?
Yeah, I would agree. I think that unfortunately, there's not a lot of motivation to do a lot of studies on diet, right? There's unfortunately not a lot of money behind those things, and that sort of is one aspect of it. But from a dietary standpoint, I agree with Raina. You tell patients to focus on the things that work well for them and don't trigger symptoms. In terms of what the data has shown, a low FODMAP diet is one that people have focused a lot on, and has shown some evidence to be effective. Essentially, you're looking at byproducts in food that our gut was never meant to break down or be exposed to. And some of the byproducts of these foods cause symptoms when exposed to our GI tract and our bacteria. So this works by trying to eliminate foods that have been identified as high FODMAP foods, and then slowly work your way into reincorporating these foods that you do consume that are high in FODMAP to see if they trigger symptoms for you. It's the good thing about FODMAP compared to like a gluten-free diet is that with a gluten-free diet, you're actually avoiding a lot of important whole grains. which are very beneficial to your gut and to your overall health. So with FODMAP, you don't do that, and you do get to consume those grains. The other thing that's been shown from a GI standpoint is fats. Obviously, more unsaturated fats can be problematic from an IBS standpoint. And I agree with Reina that in terms of IBD and Crohn's disease and ulcerative colitis, the Mediterranean diet has some strong benefits to it, as does cooking with cumin. So there's some studies that have shown cooking with cumin or even taking a cumin supplement can be helpful in things like ulcerative colitis as a secondary or tertiary agent when talking about treatment.
Thank you. Dr. Starbell, anything to add?
Sure. I mean, I think Dr. Olson and Dr. Sohal explained it very well. I think it's reasonable to offer patients, for example, mainly patients with constipation, to try with a high fiber diet, or even ask them to try some over-the-counter fiber supplements. People respond differently to fiber supplementations, but in people with constipation, a lot of time increasing their fiber in their diets can help with the constipation and relieve the abdominal discomfort. It is reasonable to try to avoid certain food that can produce a lot of gas, especially with people with flatulence, discomfort, gasiness, like certain vegetables that are, beans and cauliflower, broccoli, those kind of things that can produce a lot of gas. I tell my patient to try to avoid them and see if it makes a difference. If it makes a difference, great. If it doesn't make a difference, go back to eating them. Same thing for dairy products. There are a lot of people with IBS, like Dr. Olson mentioned, who have some degree of lactose intolerance. So I tell them, let's try to avoid dairy completely for a couple of weeks and see what happens. If they tell me, hey, there's a big difference, I feel much better, then it makes sense to try to avoid dairy on the long term. If they feel no difference, then there's no point of staying on a dairy-free diet.
Makes sense. It sounds like there's patience, there's time, keeping track of the foods that you're eating that are creating symptoms that are working well. I love, Dr. Olson, what you said about trying, if there's one food product that works really well, trying different styles of it, because you can get probably bored eating the same thing over and over again. But if you try it in a different way, in a different recipe, that might make it a little bit more exciting and fun to try a different style, and rather than eating the same thing over and over again, which I'm sure a lot of us feel that way. You don't want to have the same thing over and over again.
While we're talking about diet, I just want to comment on one thing.
Yeah.
There is a abundance of patients and maybe advice or things that they're reading online about getting allergen testing done for food. And the best thing to take away from this is that there's no evidence that any kind of blood testing for food allergens will help identify foods that trigger more GI symptoms for you. Now, obviously, if you have a peanut allergy and you get hives or an anaphylactic reaction from eating a food, we want you to avoid it. But we have a lot of patients who come to us, they've paid a lot of money out of pocket or had this test done, and they get results, they don't know what to do with them. And the fact of the matter is we don't know what to do with them. Most of the world's allergen experts don't know what to do with them because the testing is not very accurate. It doesn't help us very much. So that's one thing I would tell patients, is that if you're thinking about ordering something like that or requesting it, it generally doesn't help us long-term with trying to tailor a diet to helping you in your GI symptoms.
That's a very good point. Thanks for bringing that up. The next thing I wanted to ask about before we wrap up today's broadcast is just around the taboo around these topics. Do you think there is a taboo? There's different feelings about having conversations about these types of topics. Some people are more comfortable, some people are not, and prefer not discussing with their friends and family or even with their providers. So can you talk about, do you think that there's a taboo around this, and does that make it harder for people to come forward and have a conversation about the symptoms that they're dealing with? And if so, what do you think could be done to help raise awareness to destigmatize that issue? Dr. Olson, I'll start with you.
I do think that there is a embarrassing factor. People don't like to go around saying, oh, my stomach hurts and I have diarrhea and I have gas and I have flatulence. Like, who wants to go around talking about that? Nobody. It's mortifying. It's embarrassing. So it's embarrassing. But the more we talk about it with one another, whenever the girls are around and you start talking about your girlfriends and you're like, oh my God, you too. Oh my God, you too. And then you're like, oh, this is really, really common. I know that we've spent this entire time talking about IBS and IBD, but the reality is only about 1% of patients have IBD in America. 10 to 15% have IBS. IBS is the most common thing that people come to us to see us for. So it is definitely something that we're dealing with on a regular basis. The more we talk about it, the more you put on programs like this to make patients realize, oh gosh, so many people have this. It's not just me. I think that kind of stuff raises awareness. Anything we can do to promote fundraising, research, awareness will only help shed light on the matter. Because I don't know if we can take that embarrassing feeling away from patients around this topic.
Makes sense. Thank you. Dr. Sohal, anything to add to that?
No, Brandon said it very well. I would say that, it's that conversation, having that conversation with your provider is part of the therapy. The relationship that we have with our patients and the ability to have that kind of communication and open communication is really important, right? So the more you talk about these symptoms, the more you realize that they're prevalent, that a lot of people go through the same things. And that we have sort of tried and true methods to try to identify symptoms and triggers and things that we can use to treat it. I was laughing before because I didn't think it was too taboo, to be honest. I feel like, we see so much of it that people are happy to talk to us about their symptoms. But I do understand that. And I think that when patients hear that from us, where it's like, I see 15 to 20 patients a week who are having problems with constipation, bloating, and abdominal pain. And that's a relief for them to hear that. It definitely doesn't take away their quality of life issues that they're experiencing. But I think, anytime that we're dealing with symptoms, it's important to address them, GI or non-GI, with our physicians. And I think conversation and talking about them is always important.
Yep. And Dr. Charbel, anything for you to add?
Like Dr. Olson mentioned, IBS is very common. About 15% of people have IBS, but unfortunately, only about 15-20% of people seek some help with IBS symptoms. And it's very important for people to know that there are a lot we can do for IBS to help them. Although we cannot cure the condition completely, we can help them be in what we call remission. We can help their symptoms be as controllable as possible. We start with the simple things like we discussed before: diet modifications, fibers, and bispasmodics, etc. But there are a lot of new pharmacological options for those patients, whether they have predominance of diarrhea or constipation. So it's very important to talk to their doctors about their symptoms, because a lot of options are available and a lot of new options are on the way.
All right. Thank you very much. Yeah, it's important to have that conversation. The first step is just opening your mouth and sharing the symptoms that you're feeling. And the more you talk about it, like you said, Dr. Sohal, the more comfortable it becomes. You have wonderful experts like yourselves who you can trust and have a conversation with, a spouse, family member, partner, best friend, whoever that may be, that you can trust. Maybe start there. Be bold and hit the share button on your Facebook page today. Share this broadcast. Tell everybody how we're going to break down those stigmas and talk about these important topics, because they are very common, like you said. So thank you for that perspective. Really appreciate that. Before we wrap up, I do want to go to each of you and see if there's anything you want to make sure that our viewers walk away today thinking about, knowing anything that, what is that one message or one takeaway or anything that you're excited about that's coming down in the field of GI. Let's close the broadcast with some final thoughts. I'll start with you, Dr. Charbel.
So as we mentioned before, I think patients should feel more and more comfortable opening up and discussing those symptoms, any GI symptoms, especially new onset symptoms. I wanna emphasize that any new onset gastrointestinal symptom need to be evaluated. Patients need to talk to their doctors about it because it may not be functional, it may be structural, patients may have IBD, may have cancer. There are a lot of other gastrointestinal conditions that we haven't covered today that can also present with the new onset gastrointestinal symptoms. So it's very important to seek medical attention, talk to the doctor about it, and stay away from the internet as much as possible.
Dr. Google, like you said, Dr. Olson. Thank you, Dr. Charbel. Dr. Sohal.
I would just end by saying that, I love doing GI and practicing GI as a medical field. When it comes to patients and their quality of life, it's greatly affected from a GI standpoint by their symptoms. And that's what we're here for. We're here to be your helper. We're here to listen to your problems. We're here to help you understand it better. And I think the better understanding you have of your own condition, the easier it is to understand the treatment and to respond to treatment. And to not be hesitant to come to talk to GI doctors about your symptoms. My daughter tells all of her friends that I'm a poopy doctor, and we love talking about this, and we're happy to talk to patients about their abdominal pain and their bowel movements. When you have a patient come in and say that they're feeling significantly better and they don't worry about their bowel movements or their pain anymore, and they can focus on more important things in life, that's why we do what we do.
Thank you so much. Yeah, it makes sense. It could significantly impact your life. I mean, my husband has IBS and he won't go places because he completely changes his life to deal with these symptoms. So it's important, to get them and have we talk about it a lot as well in our house.
You need to have him come see one of us.
Yes, I will. He's actually watching right now, so maybe he'll tell me afterward. Let's do that. Dr. Olson, how about you? What are your final thoughts?
I would say don't die of embarrassment. If there are symptoms that you are concerned about, don't be embarrassed about it. Come in, talk to us about it. It's a safe space. We can help you. Not everything that brings you in is dangerous. It can be incredibly nothing, like a bleeding from a hemorrhoid, and there's an easy fix for that. So don't die of embarrassment. Come in and let us guide you through it. Let us hold your hand to get you through the harder stuff.
Thank you so much. Yeah, you guys are the experts. You're used to seeing all kinds of different patients. There's nothing to be embarrassed about. So thank you all very much for those final thoughts. And thank you to our viewers. If you would like to make an appointment or more information about our GI services at MedStar Montgomery Medical Center, you can call 301-774-8962. We will post that phone number in the comments as well for you to access. Thank you very much to the three of you. We really appreciate the time. I learned a lot. I hope our viewers did as well. So thank you very much for everything that you do and for all the knowledge that you shared today.
My pleasure. Thanks for having us.
Thank you. Thanks.